Friends, welcome to my workplace at Ranaghat, West Bengal, India. I have beautiful hands-on training program. You may contact me by WhatsApp or email. Let us observe this totally unedited surgery. The ocular surface is thoroughly irrigated, applying few drops of povidone iodine. And now we're going to proper magnification. And this is the main incision, the 2.8 millimeter steel keratome. The anterior chamber is then filled up with 2% hydroxypropyl methyl cellulose. Then a side port is made on the left side of the main incision. You can see that the cataract is of medium density, about grade 3 nuclear sclerosis. This is the capsulorhexis with the help of a utrata forceps. Rhexis with utrata is a must to learn. You may be doing capsulorhexis with needle, but please try capsulorhexis in routine cases with utrata forceps. Then you will be able to do double rhexis in intumescent cataracts. Hydrodissection is done, nucleus is rotated, and now we are going to enlarge the main wound just by 0.1 millimeter, because at the end of this surgery I'm going to use a B cartridge and for easy entry and exit of the Phaco needle, I'm enlarging the main wound at this time itself. And now watch direct vertical chop. The tip is buried into the substance of the nucleus and the chopper is placed just in front and a nice crack is obtained. This is direct vertical chop. And as we get 4 pieces, we start pulling each nuclear piece at the center and start emulsifying. If necessary, we can subdivide these large fragments into smaller pieces. We must always emulsify the pieces in the central 3 millimeter safe zone. We must not apply ultrasonic energy in the periphery. Ultrasonic energy is set at 60% in this case, but we are using maybe 40% ultrasonic energy. Vacuum is 480 millimeter of mercury and flow rate is 48 ml per minute. And now in this case, I'm going to use coaxial irrigation aspiration. A lot of cortex is remaining, and now I am getting into the belief that coaxial IA is much faster than either Synco or bimanual IA. And we need not make another side port. We need not make a bigger side port to introduce Synco in such cases. If we use, coaxial irrigation aspiration device. So coaxial eye is a beautiful thing. We can go for it, and it is very fast, very quick, and very safe. And now we have to polish the posterior capsule a little bit. I do hydro polish without aspirating probe, just use the fluid jet to polish the posterior capsule. And now hydro implantation of a single piece monofocal intraocular lens is being done. Just by a push of the left hand irrigating probe, the trailing haptic goes into the capsular bag. You don't need a dialer for this. This is a little bit of moxifloxacin, and the side port is closed, and a final lavage of the anterior chamber is done with the help of a 23G Simcoe cannula. And formation of the anterior chamber is very good with Simcoe, and the main wound doesn't require any hydration if we form the anterior chamber with Simcoe cannula. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Please learn direct vertical chop. Please learn how to use coaxial irrigation aspiration device. Be a great surgeon and serve your patients with love, respect, compassion, and great surgical competence.